Hello and welcome. Today, we're diving deep into one of the most perplexing and, frankly, dangerous subtypes of breast cancer. We're going to break down the complex clinical, imaging, and histopathological features of what's known as diffusely infiltrating breast cancer, all based on a really important paper from the European Journal of Radiology. So, right at the heart of all this is a major clinical paradox. You've got a cancer that, when you look at its standard markers, looks like it should have a pretty good prognosis. But the long-term data tells a completely different and much darker story. This mismatch, it really challenges how we diagnose and treat this disease, and it's exactly what this research digs into. So, what does this cancer actually look like on a mammogram? This is absolutely key. Unlike a typical cancer that forms a lump you can spot, this subtype shows up as this extensive architectural distortion. It almost looks like a spider's web. You can see it there in the circled area. It's subtle, it just blends in, and there's no central tumor mass to easily point to. And right there, that's the first huge hurdle in diagnosing. To really get a handle on this disease, we first need to unmask its telltale signs across different types of imaging. So let's walk through how these, imaging biomarkers help us track down this very elusive cancer. Okay, let's look at a case. Here we've got the medial lateral oblique, or MLO, views of the left breast. Now look closely at the central and lateral parts. You can see this widespread, kind of haphazard pattern. This is not some neat, contained little lesion. It's an extensive architectural distortion that's already pushing into both the skin and the chest. Sticking with the same case, the craniocaudal, or CC, views just confirm what we saw in the MLOs. Now, take a look at image E. That's the handheld ultrasound. It gives us an even clearer picture of just how extensive this malignancy is. And again, notice what's missing. There's no central mass, and there are no associated microcalcifications, two of the most common signs we hunt for in other breast cancers. Okay, so this brings us to the most critical point, how this cancer interacts with the tissue around it. This table really sums up the key differences when you compare it to a typical axonar breast cancer, or ABB. Now, a typical ABB bulges outwards, creating a convex or rounded border. But this diffuse type, it actually pulls the tissue inward, creating concave contours. It blends in, doesn't form a mass, and doesn't have those calcifications. These differences are absolutely fundamental to even finding it. And this image just illustrates that point perfectly. On the left, you can see that architectural distortion with its classic concave borders. It's subtly mimicking the look of normal tissue. It's really hard to see where the cancer stops and healthy tissue begins. Now compare that with the image on the right, a typical acinar breast cancer. It's a distinct, star-shaped mass with bulging, convex borders that are clearly pushing into the surrounding tissue. I mean, the difference is night and day. So this unusual growth pattern leads to another really key clinical sign, the shrinking breast. Because the cancer is creating so much fibrous tissue, it causes this desmoplastic reaction that literally pulls the breast tissue inward, making the entire breast actually shrink in size. And as you can see from the mammogram, the pathology slice, and the MRI, the result is this extensive distortion and a noticeable drop in the breast's volume. Okay, let's shift gears from the imaging signs and see what's actually going on at the tissue level. What's the underlying pathology that creates these really unique features we see on the scans? Now, what's really fascinating here is the direct link between the radiology and the pathology. In image E, that's a radiograph of the surgical specimen slice, and it shows the exact same spider's web pattern from the mammogram. Right next to it, in image F, is the large format histology slide of that exact piece of tissue. The correlation is perfect. This technique is so key to understanding the disease structure, showing us precisely where that architectural distortion is coming from. And when we zoom in on that histology, the cause becomes crystal clear. This isn't just a tumor made of malignant cells. It's a massive, excessive proliferation of fibrous, cancer-associated connective tissue. This fibrosis is the real culprit. It's what's disrupting the normal, orderly structure of the breast and creating that haphazard pattern that we see as architectural distortion. So now we come back to that central paradox. We've seen what this cancer looks like, but why is it so deadly when its traditional biomarkers often look, well, reassuringly favorable? Let's just start with the bottom line. This Kaplan-Meier curve, which is based on decades of follow-up data from Dalarna County, Sweden, is, well, it's sobering. Women diagnosed with this diffusely infiltrating cancer have only a 60% cumulative survival rate at 20 years. That is a truly dismal outcome. And to put that 60% figure in context, Just look at this comparison. The survival for this cancer, that's the red line, is just as poor as it is for large, aggressive acinar breast cancers over 15 millimeters. But here's the kicker. For those acinar cancers, finding them early when they're small, that's the green line, dramatically improves survival up to 84%. But for this diffuse type, neither screening nor our modern therapies have managed to budge that poor long-term outcome. The data reveals a really profound resistance to our standard treatments. Take post-operative radiotherapy, for example, a cornerstone of adjuvant therapy. This graph shows pretty much no difference in 20-year survival between patients who got it, the blue line, and those who didn't, the black line. The therapy is, for all intents and purposes, ineffective for this specific subtype. And the story is just frustratingly similar for chemotherapy. Once again, you compare the survival curves of patients who did and did not get chemo, and there's no significant long-term benefit. This consistent failure of our best adjuvant therapies, it's a huge clue that we're dealing with a malignancy that has a fundamentally different biology. And this brings us right back to those deceptive biomarkers. In most breast cancers, being estrogen receptor positive is a good sign, but not here. Look at the graph on the left. Even ER-positive patients have a poor 20-year survival of just 68%. The markers we rely on to guide treatment and predict outcomes are simply not reliable for this type of cancer. Okay, so given the unique imaging, the distinct pathology, and the failure of our current treatments, where do we go from here? The research points to one clear conclusion. We need a call for new approaches. And here's one final crucial piece of the puzzle. It comes from E-coherent staining. Now, E-coherent is a protein that basically helps cells stick together. Normal lobular cells, which you see here in dark brown, are strongly positive for it. But the cancer cells of this disease, circled there in the oval, are completely unstained. They're E-coherent negative. This really challenges the conventional name infiltrating lobular carcinoma because these cancer cells don't share this key feature of the cells they supposedly come from. And that leads us to this really powerful conclusion from the authors. They argue that the very name we use for this cancer is misleading. By calling it lobular, we're not only probably wrong about its origin, but more importantly, we are causing clinicians to underestimate its truly aggressive biological potential. So, let's just boil this all down. What are the key takeaways? First, this cancer shows up as architectural distortion with concave contours. Second, this is caused by a massive amount of fibrous tissue. Third, its standard biomarkers look good, but they're completely deceptive. Fourth, it's resistant to our current therapies like radiation and chemo. And finally, all of this demands that we rethink our terminology and develop entirely new strategies to fight it. This vital research, led by Professor Laszlo Tabar and his group, is so much more than just an academic paper. It's a clear and urgent call to action for all of us, radiologists, pathologists, and oncologists. We have to recognize the unique features of this disease, adopt new terminology and diagnostic techniques, and work to develop innovative therapies if we're ever going to improve the dismal outcome for patients with this incredibly challenging malignancy.